Hello, students. Today we're going to be talking about anesthesia. So first we're going to go through some of your PowerPoint slides, and then we are going to go through the guidelines. So the first thing is there are two different types of people who deal with these codes. The first is the anesthesiologists themselves, the specialist of anesthesia. Now, again, they can be independent practices or they can be hospital employees. And some of them do both. So if you end up working for anesthesia, one of the first things we need to know is, does the doctor work for one or the other or both? Some anesthesiologists have their own office where they do pain relief, and they also deal in the hospital. Now, all of these services are reported separately. So when a patient has a surgery done, the anesthesia itself gets reported separately by the anesthesiologist. Oh, the other person who can use these codes are what we call the CRNAs, the Certified Registered Nurse Anesthetists. They are the nurse practitioner version of the anesthesiologist. Again, most of the time, we deal with anesthesia to relieve pain, but we also use it to manage patients. For instance, an induced coma uses anesthesia. So if someone needs to be in induced coma after major surgery to let their body heal, that's one of the reasons we use it for. Again, that also goes for life functions. When someone has something like a near drowning, a lot of times we'll put them in an induced coma to, again, allow them to do that. The other use is for resuscitation. If someone is not breathing properly, anesthesia can kickstart their system. Now, the most common type of anesthesia that we hear about is endotracheal. Why? Because this is going down the throat. A lot of people confuse this with the mask that goes over your mouth. So endotracheal into the trachea, and you can see right here, they use this mechanism to hold the tongue down and to actually get the tubing into the trachea so that they can make sure we can keep that airway open, and to administer anesthesia, because when we inhale anesthesia, it goes right down into our respiratory tract, ends up in those little alveoli, the air sacs at the end of our bronchioles, and then that's where that blood-air exchange is happening. Other types of anesthesia we're going to see local anesthesia. Local anesthesia is either an injection or topical. These tend to go into one of the three layers of skin, epidermis, dermis, or subcutaneous tissue. And on occasion, it might go into the fascia or muscle. And what we do is we put this around or underneath the area. So for instance, if this is, let's say, a cyst, the doctor is going to numb the top where they're going to cut, and they're probably going to numb around the area and possibly under the area so that when they've removed this, the patient's not feeling pain even though they're completely awake. Now, there's a couple of other types. There's the epidural. This is best known as the epidural for labor and delivery. But other people can get an epidural, spinal surgery, surgeries dealing with the lower half of the body, depending on where the nerve is. We might do a nerve block. We can also do epidurals for when the intervertebral discs, the discs in between the vertebrae, start sliding or slipping. And then we have regional. Regional is what we call a field or a nerve. So for instance, instead of doing surgery for carpal tunnel syndrome, we can do a series of injections, and we inject around the nerve so it can calm down the area. However, we can also block an entire region, like the entire left arm or the right leg from the knee down. This also includes spinal epidural, which we use a lot with surgeries of the head and neck. We also have what we call PCA, patient-controlled analgesia. This is better known as the button. And the button, basically, the doctor sets the anesthesia and says every so many minutes, if someone presses the button, they will get a drug released into their system. So after the drug gets released, if there is a time frame, that patient can keep pushing that button, but no extra drugs are going to come in. Now, I have this when I was in labor and delivery. I had the PCA with my epidural. So it was an epidural catheter instead of just an epidural injection. So I was able to use that button. But again, a lot of times it's used for post-op pain and chronic pain. Moderate, also known as conscious sedation, has their own set of codes. This is when the patient is in a decreased state of consciousness. So they're in a sleep-like state, but they can respond. However, they don't remember what they've said, versus general anesthesia, which is what we've been talking about, the epidural, sorry, not the epidural, the endotracheal. That means the patient becomes unconscious. Now, these codes are all in the medicine section. We'll be covering that towards the end of our course. And these are divided by age, time, and the person providing the services. So if you end up working for a gastroenterologist and they do a lot of colonoscopies, you're going to be using the colonoscopy surgical code with a moderate sedation code. Again, these are different from general anesthesia. Now, the anesthesia format, it goes by anatomic site and then what type of anesthesia. And so the first thing that we separate out is by anatomic site, where in the body are we doing the procedure that we're giving anesthesia for, and then the type of procedure as the second division. Now, along with all of this, you're going to see B, T, and M a lot. So anesthesiologists and CRNAs get paid for every minute that the patient is under sedation. And because of that, this is the calculation. Now, what I want to tell you guys is that most of the time, if you work for anesthesiology, you will just put in the base units, the time units, the modifying units, and it will spit out the amount of money that you should be getting reimbursed for. But we should know how to do this because you may get a question on a certification test. On my CPC exam, I got a question where they gave me the base units, the time units, the modifying units, the conversion factor, and I had to pick out of the 4 answers which one of them was correct. So let's start. Every single anesthesia code has a base unit assigned to it. And so the base units are based off of the complexity of the surgery. So a surgery on the muscle of the left arm is going to have a smaller base unit than a heart transplant surgery. That's going to have a much higher base unit. Okay, so base units are based on the complexity of the procedure the patient's having. Then we have time units. Most places in the country, time units are in 15-minute increments. So every hour is separated into 4 time units. So the doctor tells us how many minutes and we tell them how many units in the system. So for instance, if someone had a 60-minute surgery, their time unit would be 4. Because we take 60 minutes divided by 15, and that gives us 4 units of time. Now, the modifying factors are a combination of the physical status modifiers and the qualifying circumstances. Not all of them have a unit assigned to them. Some of them are 0, but again, the more complex the case is, the more money that they get in reimbursement because of it. So the base unit, again, is published by what we call the RVG, the Relative Value Guide, published by the ASA. okay, the American Society for Anesthesiologists. Now, again, the national unit value is something that we use throughout the country. So it doesn't matter where you live, the base unit is not going to change. Okay, again, these are solely based on the complexity of the procedure. So the relative value guide lists all the CPT anesthesia codes, and it has not only the units, it also has any comments that you might need to know. So if you end up becoming solely an anesthesiology coder, then this is going to be one of your major resources that you use. So this is what the relative value guide looks like. For each code, there's different base units. So for a second, let's look at the difference. So let's look at this first code, 00100, has a base unit of 5. 00100 is anesthesia for procedures on salivary glands, including a biopsy. So if we're doing a biopsy of the submandibular salivary gland, then the base unit is 5. That's a relatively small surgery, right? We're just doing a biopsy. We're taking a piece of tissue out of the body. But let's look at this one that says 11. It's 00210. And 00210 is for anesthesia for intracranial procedures not otherwise specified. So again, intracranial, inside the skull. So again, because we're in a more complex area of the body, the base unit is higher. Now again, the relative value guide also deals with what we call the conversion factor. So every area of the country has its own conversion factor. Connecticut is one area. So we have one amount no matter whether or not the patient is getting services done in Hartford or New Haven, it doesn't matter. But in larger states like New York State and Texas, California, they do have different conversion factors. So for instance, as they say here, Medicare for North Carolina in 2015, their conversion factor was 2182. So what we would do is we would add up the base plus the time units plus any modifying factor units and times it by 2182 to get our price. And again, most commonly, time is in 15-minute increments. That is the most common that you will find. So again, 15 minutes equals 1 unit. So again, we're doing simple division and just breaking out the calculator if we want to make sure we're correct. Again, in the system, you'll put in the total amount of minutes. It should spit you out the amount of units. Now, as our guidelines tell us, anesthesia time begins when the anesthesiologist begins to prep the patient, okay? So as soon as the anesthesiologist walks into the surgery room and grabs that needle or mask or whatever it ends up being, that's when time starts. Time continues throughout all of the procedure, and time officially ends when the anesthesiologist has handed off the patient to the nursing staff. So as our example says, if the patient started at 9 a.m. and was discharged to the unit in the nursing to the nursing staff at 1:30, it would be 270 minutes. Okay, so now this is what I'm going to do. Okay, I'm going to bring up my calculator. And remember, every computer you're going to be working at in the field is going to have a calculator. Of course, you are welcome to have a desk calculator, but keep in mind, when we're talking about phones, don't take your phone out. So this is what we're going to do. We're going to do 270 divided by 15. We would get 18 units for this particular case for the 270 minutes, okay? So again, we're doing some basic math, nothing major. Again, the modifying units are the P1 through P6 modifiers, okay? And they're based off of risk factors. So again, the more risks the patient has to undergo surgery, the more units we get to add to the calculation. However, this is not reported for Medicare. So again, Medicare coders tend to make more money because they have very stringent guidelines in what they want from their billers and coders. Now again, our physical status modifiers, okay? So this is the physical status of the patient before they have the procedure. So if you have a 7-year-old that needs to get a tonsillectomy, okay, otherwise they're normal and healthy, they're going to be a P1. Okay, a P2 is like a chronic disease that is controlled asthma, controlled hypertension, controlled diabetes. It can be controlled by whether it's diet, it could be controlled by medication, but it's a controlled disease. Now, severe systemic diseases are one of two things. They are either chronic conditions that are uncontrolled, uncontrolled diabetes, uncontrolled asthma, uncontrolled hypertension, or severe systemic diseases that, again, could possibly endanger the patient. Think congestive heart failure, COPD for our chronic obstructive pulmonary disorders, okay, much more severe disorders. Then we get to P4. P4 is a systemic disease that is a constant threat to life. So for instance, if this is sepsis or severe sepsis, which is blood poisoning, that's when a microbe, usually a bacteria, gets into the bloodstream and it starts to keep spreading all over, and it gets into the bloodstream and it can start shutting down organs. And so that would be considered more of a severe systemic disease. Remember, systemic, it goes through the whole system. It affects the whole body. Okay. Now, a P5 is going to be more of our emergency and trauma situations, where if we don't get that person into surgery, they will not survive. And that's where you'll see in your book, it says the term moribund. Moribund is a nice way to say that the patient is dying if we do not perform this procedure. P6 is for our brain dead patients. These are for people who are going to donate their organs. Now, we do not know if the brain is brain dead, can the body still feel pain? We just don't know enough about this yet. So if someone is going to donate an organ or multiple organs, no matter what, they are going to anesthetize the person before they stop their heart so they can harvest those organs. And this is not something that's billed out. If someone's donating their organs, it will not be billed out to their insurance, but it's to ensure that the anesthesiologists are doing the proper process. Now, the other modifying units are the qualifying circumstances. Okay, so these are both in your green guidelines in anesthesia and in the medicine section. Again, these are also not reported for Medicare. And these, again, are going to give us extra circumstances. So 99100 is for patients younger than 1 and older than 70. 99116 is for total body hypothermia. This is when they cool the body down. They do this a lot for near drownings, for heart attacks, for some strokes. And basically, as you cool the body down, it slows down the cell movement so that you can stabilize the person and try to get treatment before there's further damage. 99135 is controlled hypotension. So controlled hypotension is when we add blood thinners so that we can keep the blood circulating around in a slightly thinner capacity. This happens a lot for, again, transplant procedures, making sure the blood is not clotting and it's still moving through the body. And then 99140 is the anesthesia complicated by emergency conditions. And as the notation right here tells you, an emergency is defined as existing when a delay in treatment of the patient would lead to a significant increase in threat to life or body part. So again, if someone has a crush injury from a car accident and we need to amputate that foot now, that's going to be a 99140. Now again, a couple things you'll notice about these codes, they are all add-on codes. So they are always going to be listed in addition to the anesthesia code. The anesthesia code goes first, then the P modifier, then the add-on code. Okay, so again, this is what we're going to end up doing. We're going to be doing the base units plus the time units plus the modifying circumstances equals the total units. We take the total units times the conversion factor, and this equals how much we're supposed to get in payment. And again, the conversion factor is different for every geographic area. So again, just to give you an idea of some different types of conversion factors, these are from 2015. So again, Manhattan is 2542, the New York suburbs are 2631, Queens is 2632, and rest of New York is 2185. And that's because living in both the suburbs and in Manhattan or Queens is much more expensive. The standard of living is much, much higher. So they get paid a little bit more versus if you go up into mid-state in northern New York, everything is a lot cheaper. And so they get paid a little bit less. Again, it's about $4 to $5 difference between the city and the rest of New York. But again, you know, you can get a 300 square foot studio for $500,000, you know, in New York City. So we have to keep that stuff in mind. The standard of living is much higher, so they get paid more for those areas. Now, when we do multiple procedures, okay, we deal with the length of time, and we deal specifically with what procedure has the highest base unit, okay? So we can only code out for a surgical procedure one code with the highest base unit, okay? So if we have a procedure with a base unit of 10 and another procedure with a base unit of 5, we will report the code only that has the base unit of 10, but we will add up the time through all of the procedure. No matter how long both of them took, we still add up all of that time. Now, these HCPCS modifiers are in your textbook, and as I'm going to show you guys, I have them written in my code book as well. So what we're going to want to do is we are going to want to talk more about how these HCPCS modifiers work and when we use them.